you can see about me. I'll be alone, dancing with no one. Tell me your troubles and doubts, giving me everything inside now. Well, love's straight, so real in the dark. Think of the tender things that we were working on. The slow change can pull us apart. When the light gets into your heart, baby, don't you forget about me.
Absolutely.
Don't you forget about me. Will you stand
Dr. Schillerstrom, can you give us a quick test?
with my way that never loved me? Rain keeps falling, rain keeps falling.
All right, let's get started. If you're in line for refreshments, please stay in line. I'm sure you won't miss a thing. All right, so we're almost there, right? Oh my God, the longest day. We're so close. So close to happy hour. And then here we are. Okay. That'll be good. So we're going to talk about alcohol. Alcohol and hours. So we're talking about the epidemiology of alcohol use disorders in the elderly. Talk about the effects of alcohol use disorders on various organ systems. Talk about different screening questions specific for elders. Talk about how to quantify alcohol consumption, and then talk a little about the mortality and morbidity of alcohol use disorders. Right, so epidemiology first. So about 50 to 60% of older adults are abstainers. If you ask them how much alcohol have you had in the last year, they'll say none, right? None. 50 to 60%. Which means that 50 to 40% of them are users, right? See how that works? That's how statistics works there. Yeah. So about 40 to 50% are alcohol users. 15% will screen positive for at-risk or problem drinking. We'll talk about what that is. 30% have a lifetime history of alcohol abuse or dependence. And so what's the difference between abuse and dependence? Do we use those words anymore? You know? What's the difference? Dependence is on a daily basis? Okay, kind of. Yeah, that's kind of right. That's right. That's kind of right. Yeah. Yeah, so the so we kind of go to new DSM terminology. So DSM-4, you either had an alcohol abuse disorder or an alcohol dependence disorder. They got rid of that. When they revised it to DSM-5, it's just now an alcohol use disorder. Abuse used to mean that alcohol was adversely affecting your life, but you didn't have any physical symptoms from it. You didn't experience tolerance or withdrawal. And if you experienced tolerance or withdrawal, then it was dependence. But they got rid of that, and they reclassified, when they did all the reclassifications a couple of years ago, they got rid of alcohol dependence, they got rid of alcohol abuse, and they just said alcohol use disorder. And so alcohol use disorder now is, so you can screen yourself right now. You can decide for yourself if you have an alcohol use disorder. So I won't ask for a show of hands of who has cravings, but nonetheless, in your own mind, you can keep track here. So if alcohol is taken in larger amounts than intended, if you have unsuccessful efforts to limit or discontinue consumption, a great deal of time is spent related to trying to obtain alcohol, or a great deal amount of time is spent recovering from the effects of alcohol. Cravings, you're unable to fulfill major role obligations. So this would be like you're not able to do your job because of your alcoholic use. Continued use despite interpersonal problems created by alcohol, so it's like marital problems or problems with friends or other family. If important activities, if you give up important activities, that's another symptom. Recurrent use in physically hazardous situations. Physical problems caused by alcohol, this would be if you have like cirrhosis, or if you're getting ulcers, physical ulcers from alcohol, somehow it's affecting your physiology. And then finally, tolerance and withdrawal. So what is tolerance? What do we mean by that? Yeah, tolerance is when you have to use more and more and more of the substance to get the same effect, right? More and more and more of the substance to get the same effect. And then there's withdrawal, so if you stop using alcohol in this case, if you have withdrawal symptoms, and we'll talk about what alcohol withdrawal symptoms are, if you have withdrawals, the shakes, whatever, well, when you're coming off of alcohol, then that's another one of the criteria. So this is divided up into either mild, moderate, or severe based on the number of symptoms you have. I believe mild is if you have 2 to 3, moderate is like 4 to 6, and severe would be if you had more than 6. So when taking an alcohol history, what question do you ask first? Do you drink? When did you start drinking? Do you want to drink now? No. So I always just ask, how much alcohol do you drink per week? That's the question I ask. I always just assume that they are, right? Half of them aren't. So I always just assume that they are. And so just in a very matter-of-fact way, when I'm going through the social history, I'll say, can you tell me how much alcohol, how many drinks do you have per week? Okay? And if they don't drink, no one who doesn't drink is ever offended by that question. They'll just say, oh, I don't drink. And then I say, okay. So if I ask them how many drinks do they have per week, what question should I ask second? How much? What do you drink? Ah, okay. You have discriminating taste. Okay, I like that. Let's say I drink whatever 8 beers a week. I always say, well, what size are the cans, right? So I always want to know kind of how, if they say they drink a 6-pack, I've kind of learned the hard way that not all 6-packs are created equally. So what size are the cans? And the question I asked third was also already mentioned, which is, when was your last drink? When was your last drink? Okay. And so these are kind of questions that I get started with when I'm doing alcohol histories. We can talk about alcohol quantification. And so whenever I talk about alcohol, what I always find is that this is especially to my medical students. I mean, it's probably true here. Is that I found whenever I'm giving an alcohol talk, the variety of experience of the audience is always a very broad bell-shaped curve, where some audience members have like minimal, if any, experience with alcohol, and other audience members have a lot of experience with alcohol. And so just to kind of get everybody on the same page, especially with quantification, I have this kind of chart just to kind of get us on the same page. So the first thing I always tell my medical students is that when I'm talking about cans of beer, I'm talking about 12-ounce cans of beer, okay? 12-ounce cans, not 18-ounce, not 24-ounce. I'm talking about 12-ounce cans of beer. And kind of all of life can be related to a 12-ounce can of beer. Okay. And so patients will usually tell me one of these things. They'll say, well, I drink a 6-pack a day, I drink a 12-pack a day, an 18-pack at a specialty store, a case. Sometimes my medical students get a little confused about the case. So this is when they're working at the VA. When my medical students are working at the VA, the vets will tell them they drink a case a day, and my students will confuse a case with a 12-pack, right? But then when I have to tell them, no, a case is actually 24 beers, not 12 beers. So if they say they're drinking a case, then they're drinking 24. So say they're drinking liquor. So for liquor, with liquor, I'm also talking about 80 proof liquor. Okay? I know liquor comes in all sorts of proofs. So what does it mean if something's 80 proof? What does that mean? 40% alcohol by volume, right? 80 proof is 40% alcohol by volume. So 80 proof is your typical, that's the typical content of your whiskeys, tequilas, rums, vodkas. Most of those are 80 proof, okay? Of course there's a variety between brands, right? So if you like your vodka with a fruity flavor, it's going to lower the proof if you like, whatever. Others, it'll be higher, okay? But on average, most liquors are 80 proof. The whiskeys, the tequilas, the rums, the vodkas are 80 proof. And so how will patients quantify the amount of liquor that they drink? Well, like what are the terms that they use? I drink what a day? Shots. Somebody say I drink however many shots a day. Okay. How much is a shot? How much is that? You know? Well, in the valley it's 3 ounces, but in real life it's 1.5 ounces. So like if you go to bartender school, a shot is 1.5 ounces. Okay, 1.5 ounces, bartender school, a shot is 1.5 ounces. Okay, so they might say they drink shots, but we're never really convinced that they're measuring out 1.5 ounces, are they? They're just like slugging it and they're saying that's a shot. Okay, so, but 1.5 ounces is a shot. What other quantity or what other term might they say for the amount of alcohol that they drink? Okay. Fingers. I don't know that. What's that? Oh, okay, that would be like a shot too. Okay, what else might they say? They just drink beer, but what about this is for liquor, what else? So they might say like I drink a pint, or a liter, or a fifth, right? Right, maybe, Doc, I drink a fifth a day, right? A fifth a day. In fact, that's pretty common, right? You'll hear that. You'll hear people who say they drink a fifth a day, a fifth a day. So a fifth, if you hear someone say they drink a fifth or a fifth a day, why is it called a fifth? Why is it a fifth? What's it a fifth of? It's a fifth of a gallon. That's exactly right. So a fifth is a fifth of a gallon. So a fifth is 750 cc's, right? 750 cc's is a fifth. So in your mind, right now, if you can picture a bottle of wine, like a regular bottle of wine, not the bonus bottle, not the box of wine, not the cube, just think of a regular bottle of wine. A regular bottle of wine is 750 cc's. That's the volume. That's 750 cc's. A bottle of wine is 750 cc's. That would be a fifth. That would be a fifth of a gallon. Nobody ever says they drink a fifth of wine a day. That would be weird, okay? But they will say they drink a fifth of whiskey or a fifth of vodka or whatever. So a fifth of 80 proof liquor is equal to 750 cc's, which has the same amount of alcohol as 18 12-ounce beers. Okay? 18 12-ounce beers is the same as drinking a fifth of 80 proof liquor a day. A shot is 1.5 ounces. So a shot, a 12-ounce can of beer, has the same amount of alcohol in it as a 1.5 ounce shot of 80 proof liquor, which has the same amount of alcohol in it as a 5 ounce glass of wine. Okay, so a 5 ounce glass of wine, same as 1.5 ounce 80 proof liquor, same as 12 ounces of beer. Okay, those are equivalent. Let's see here. So by that, 6 shots should be the same as a 6-pack of beer. But again, as was said over here, if your idea of a shot is 3 ounces, well then all of a sudden now the math gets a little more complicated, right? So, but in bartender school, 1.5 ounces, so 6 shots would be the same as a 6-pack. A pint is the same as a 12-pack. A liter is the same as a case. A liter of 80 proof liquor is the same as a case. What's a handle? Do you know what a handle is? A handle is 1.75 liters. Sometimes you'll hear that. They'll drink a handle. That would be 1 point. That's a lot to drink in a day. I've never had a patient who told me that they drink that much in a day. So, and then with wine, it's easy. It's just 1 bottle of wine, 2 bottles of wine, 3 bottles of wine, 4. Okay. So with wine, a bottle of wine is the same, has the same amount of alcohol in it as a 6-pack of beer, which has the same amount as 6 80 proof 1.5 ounce shots. Okay. So if you're taking alcohol histories and they say, well, doc, I drink a fifth a day, and a 6-pack of beer, right? Then in your mind you can say, okay, a fifth a day, that's equal to 18 beers. Rather than 6, that's the same as drinking a case a day. Okay? That'd be the same as drinking a case a day. Okay? So this kind of gives you some sort of insight maybe into sort of the terminology and the rough equivalents and all of that. All right? So what is the legal limit in Texas? What is it? 0.08. 0.08 what? 0.08 grams per deciliter. Okay, so the units are grams per deciliter. So if you're in a hospital, if you're drawing blood alcohol levels in a hospital, do you ever get any number that looks like 0.08? You don't. What number would you get? In most hospital labs, what number would you get instead? Do you know? You get 80. Because in hospital labs, they tend to measure them in milligrams per deciliter, not grams per deciliter. So 0.08 or 80, depending on the units, is the legal limit in Texas. So the legal limit in Texas is 0.08. So how many drinks does it take young adults to get to that legal limit? How many drinks in an hour puts you at 0.08? An ounce in an hour, and by drinks I mean either 1.5 ounces of liquor, 5-ounce glasses of wine, or 12-ounce cans of beer. How many drinks does it take to get to 0.08? For most young people? 2. That's exactly right. 2. So 2 drinks. So this isn't, I'm going to drink, and then I'm going to go eat some pretzels, and then I'm going to go talk, and then I'm going to come back and drink. Now this is just drinking at a steady rate within an hour. 2 drinks gets most young adults at or above 0.08. 2 drinks in an hour. Okay? So how many drinks does it take older adults to get to the legal limit? Is it different? Is it different? Does it take more or less? Less, right? So metabolism has changed, right? So older adults don't have the metabolic power of younger people. And so actually for older adults, it takes fewer drinks to get to that limit than younger adults because of the efficiency of their metabolism. Another reason why has to do with all the medications that they take, right? So older adults take a lot of different medications. Some of them do. Some adults, many older adults take lots of medications, and the medications affect the way that the liver metabolizes the alcohol. So these medications can either speed up or more often block or slow down the enzymes that process alcohol. And so that's another reason why. Not only do they just have a natural slower metabolic physiology, but then when you compound it with the medications that they take, now it even slows it down that much more. So how long? Let's see. Yeah. Good. Okay. So you know, in San Antonio, it's almost Fiesta time. In fact, it is Fiesta, right? Fiesta, big citywide party in San Antonio. So we will have patients who are showing up to the University Hospital emergency room with blood alcohol levels of 350, right? So that'd be like 0.35, right? 0.35 or 350. And we won't want them to leave until they're sober, right? So if a patient shows up to University Hospital with a blood alcohol level of 350, again, remember the legal limit is 80. If they show up to UH with a blood alcohol level of 350, and you don't feel comfortable discharging them or doing a psychiatric interview on them until they're in the sober range, so let's just say 50, how long do they sit in the ER? How long will it take to metabolize from 350 blood alcohol units to 50? With or without an IV? Either way. The IV won't speed up the metabolism. How long? 3 hours? So to go from 350 to 50 might be 3 hours? More or less? More? How much more?
8 hours.
8 hours. Let's see. I think 8 hours in the back. Yeah. So people, we metabolize about 25 units an hour. About 25 units an hour. And so if you're at 350, to go to 50, you have to drop 300 units. 300 units divided by 25 units per hour is 12 hours. So you want to know what slows down emergency rooms? It's waiting for people to sober up, right? I mean, that just slows down emergency rooms. That person's going to be sitting, taking up an emergency bed, a very expensive emergency room bed, for 12 hours as they sober up. Right? That's a long time, right? So if you're out and you're drinking and you've had whatever 3 drinks in an hour and a half and you're pretty sure you're above the limit, which you probably would be, For you to drop back down, if your blood alcohol level is pushed about 100, 110, you have to like sit there and drink coffee for an hour, right? That's what you got to do to metabolize that down, right? 25 units per hour is what you metabolize. Once, 25 units per hour is what you metabolize. And so the way alcohol is metabolized in the liver. Alcohol is metabolized, by alcohol, ADH, alcohol dehydrogenase, which becomes acetaldehyde, and then aldehyde dehydrogenase metabolizes it to acetate, and then it's excreted, right? And so in elders, what happens is not only is the metabolism just less efficient, but the medications that they take, a lot of the medications they take, affect these enzymatic processes, and therefore they're just slower, okay? So not only does it take fewer drinks for elders to get above the legal limit, but once they are above the legal limit, it takes even longer for them to metabolize it back down to sobriety, okay? Has to do with the efficiency of their systems. So older adults they tend to have increased sensitivity to alcohol. They have less body mass. So because they have less body mass, less lean body mass, because they have less body mass, they have increase in alcohol concentration. And then the interactions between the alcohol and multiple over-the-counter and prescription medications that they take also decreases metabolism. So for all these reasons, elders just tend to not do as well with processing alcohol. And so when you look at this is from the federal government, NIH, the NIAAA section of the NIH, the recommendation for elders, no more than 1 drink per day and no more than 7 drinks per week. That's the official recommendation from the NIAAA. 1 drink per day, no more than 7 drinks per week. And so for alcohol screening questions, and after we kind of go through that history, the alcohol history, and we're quantifying and trying to get a sense of how much they're drinking, these are questions that were specifically designed to be used in geriatric populations. So this is the Michigan Alcoholism Screening Test, the geriatric version, right? The geriatric version. And so the 2 or more positive answers suggest the presence of an alcohol-related problem in the past 12 months. So 2 or more suggests the possibility, okay? So then you'd have to do more probing. The questions are, when talking with others, do you ever underestimate how much you actually drink? Do you ever underestimate how much you drink? After a few drinks, have you sometimes not eaten or been able to skip a meal because you didn't feel hungry, right? After a long day's work, I'm going to come home, I'm going to drink a beer. Now I'm full. I guess I'll just go to bed, right? Does having a few drinks help decrease your shakiness or tremors? So if that's true, you're in trouble, okay? So if having drinks decreases tremors or shakiness, then we start to worry about different physiological processes. Does alcohol sometimes make it hard for you to remember parts of the day or night? Do you usually take a drink to relax or calm your nerves? Do you drink to take your mind off your problems? Have you ever increased your drinking after experiencing a loss in your life? Has a doctor or nurse ever said they were worried or concerned about your drinking? Have you ever made rules? That's kind of my favorite question is have you ever made rules to manage your drinking? That's my favorite. It's like, well, I'm only going to drink after 5. It's got to be 5 somewhere. All right? So, have you ever made rules? I'm only going to, when I go to the grocery store, I'm only going to buy 1 bottle. There's different kind of rules that people can play. When you feel lonely, does having a drink help? When you feel lonely, does having a drink help? And so on this screening questionnaire, if you have 2 or more positive answers, that would suggest the possibility of a drinking problem within the past 12 months. So what risk factors then are unique to elders? So one is they just have increased free time, right? They just have nothing but time, right? So increased free time, what does it mean? Increased disposable income, right? So they have increased free time, and they have money, that they don't necessarily need to spend that much, right? So they've got disposable income. Increased death of loved ones. Again, when you think about taking alcohol to sort of mask depression or bereavement type symptoms. And then finally, just less social responsibilities, right? They're not here right now, right? So less social responsibilities. It doesn't matter when they get up in the morning. It doesn't matter when they go to bed at night. So all of these, so there's lots of different risk factors for drinking, but these are ones that are sort of unique or more unique to elders. And so people will sometimes say, I've heard that drinking's good for you. Right? You've heard that. I've heard it's good for you. I heard you should drink to be healthy. Right? You've heard that, right? You've heard that, right? Well, you know, a glass of red wine a day or whatever. Yeah. So when you look at those studies, this is what you'll see. You'll see that mild or moderate drinking, which would be no more than 3 drinks a day in men, I think it's no more than 2 in women, might reduce cardiovascular disease, it might reduce dementia, and it might reduce the risk of some cancers. There's some studies that show this, that it could do this. The problem with these studies, 2 problems as they pertain to elders, are one, all of these studies are all the ones that I've ever seen are limited to men. They haven't found these to be true in women. Okay? So they're limited to men. And then finally, the studies are generally limited to middle-aged persons. So these are like people in their 50s, right? So we don't really know if the benefits persist when you're 70 or 80 or whatever, right? So these are limited to men and they're limited to middle-aged persons. And so what we do know is that there are detrimental effects of drinking, right? So pancreatitis, that really hurts. You know what hurts? Pancreatitis, that hurts. That's probably the worst abdominal pain you can have would be pancreatitis. Cirrhosis of the liver, cardiomyopathy, enlargement of the heart, hypertension, trauma, dementia. We know that drinking enough can cause dementia. It can cause or exacerbate depression, all these sleep disturbances, and then malnutrition and vitamin deficiencies. Sleep disturbances is probably, a lot of the patients in my clinic who drink large amounts, a lot of them actually don't drink lots of alcohol to experience the sort of the high feeling associated with alcohol consumption. They'll drink it to go to sleep. So I'll have patients who'll come to my clinic and say, I just can't fall asleep at night unless I drink a bottle of wine. And so what alcohol is good at is it is good at putting people to sleep. But what it's terrible at is keeping them asleep, right? So alcohol, it just fractures the sleep rhythms at night. It almost seems to act as a stimulant, in fact. Its metabolic products seem to act as a stimulant. So while alcohol may put you to sleep, it just doesn't keep people asleep. And in fact, it fractures their sleep and you end up having worse sleep. Right? So when we start to think about the possible benefits of drinking, the cardiovascular disease, reduced dementia, the reduced risk of some cancers, and we compare that with the known detrimental effects of drinking, what I can tell you is that I've never recommended to my patients that they drink for their health. Okay? I know, you're supposed to say like, oh, right, oh, gosh, okay. So I do think that the detrimental effects do outweigh the known detrimental effects do outweigh the possible beneficial effects, especially in the elders that I work with. Okay, so now let's talk a little bit about withdrawals, right? So let's talk about withdrawals. So this is really challenging when I do APS APS visits, because if we're pulling an elder out of their home when they could have been drinking, then there's a chance that they could go into alcohol withdrawals. And so then the recommendations that I have to make to Adult Protective Services are kind of what to look for and what to do about it if it seems like a person's going to go into alcohol withdrawal. So delirium secondary to alcohol withdrawal, what's like the common name for that? What's like the common? DTs, right? DTs, which stands for delirium tremens. DTs or delirium tremens is what delirium secondary to alcohol withdrawal is. Okay? So if a person goes into alcohol withdrawal, what % of people who go into alcohol withdrawal die? %. 20%. So 20%, if a person goes into an alcohol withdrawal delirium, or DTs as is commonly known, or as is commonly referred to, the mortality rate is 20%. And that number really has not changed over the years. It really isn't. That's been static throughout. And so what are the signs and symptoms? If someone's going into an alcohol withdrawal, what are the signs and symptoms? What do you look for? So shaking, right? So they start to get tremors, right? They start to get tremors, right? So they'll start to get tremors. They get kind of shaky, sweating. I heard sweating and kind of nervousness. What's that? What kind of behavior changes? So I heard agitation. I think that's what you're saying. Kind of more agitation and that. So what kind of hallucinations? Yeah, more visual. So more common to have visual or tactile than auditory. Right? That's right. Good. What about vital signs? So heart rate goes up or down? Up. Blood pressure goes up or down? Up. Good. Temperature goes up or down? Up. Right? So kind of the classic thing that we'll see in medicine, kind of not in psychiatry but in medicine, is that a patient might have like an emergency appendectomy. So they might have, their appendix may have gotten inflamed, they may have had to go for surgery, they'll get their appendix taken out, they'll be sent to the med-surg beds to recover from that, and then all of a sudden their pulses start to go up, their blood pressure starts to go up, and now all of a sudden you have a patient in alcohol withdrawal who's been sitting in the hospital, and you never knew that, that they were a drinker because of the emergent nature of the situation. So when does it happen? When do, from the time of last drink until the time of alcohol withdrawal onset, what's the average amount of time from time to last drink until people start to go into DTs? How long does it take from stopping drinking to going into DTs? How long does it take? 72 hours. 72 hours. So it's tricky, right? It doesn't happen immediately. It happens about 3 days later, right? After you see, so what happens is, you get your check on the 1st of the month, you drink heavy until the 20th, and then your money runs out, and now you're just holding on for the 1st of the month to come around, right? And so, so about 3 days after the last drink is the vulnerable time. So people, when they stop drinking, before they go into full DTs, a lot of times what other medical event will happen before they go into full DTs? Seizures, right? They'll have seizures. So seizures tend to occur about 12 to 48 hours after the last drink. And then the mental status changes, or the delirium, happens about 72 hours after the last drink. So that's why, that's why one of the questions that we ask right off the bat is, when was your last drink? When was your last drink? And that gives us a sense of kind of what the window is. So you can imagine that if we're going into a home, if I'm going into a home for adult protective services and alcohol is involved, and I know that, then I have to be able to tell adult protective services and the other associated agencies that this person has an alcohol withdrawal problem. The chances of them going into alcohol withdrawal are high. The mortality rate is 20%, and to be mindful of that, right? And so that they're placed in a nursing home while they're waiting to guardianship or whatever to be determined, that the nurses and everybody on board needs to know to be monitoring their vital signs, to be checking them for going into alcohol withdrawal, because the mortality rate, again, is 20%, right? We would never want to like extract someone, put them in a nursing home, and then they die because we weren't monitoring.
So,
Yeah.
through this whole process, are they drunk the whole time, or are they sober?
So are they, what do you mean, in alcohol withdrawal?
Yeah, like from the time they had their last drink.
Oh, well, they're sober. No, so the question was, are they intoxicated or drunk during this process, or do they ever sober up? No, they sober up. So they'll sober up within a day, really. They'll sober up within a day. They'll be alcohol-free for another 2 days, and then the withdrawal happens. And that's why it can kind of like sneak up on people unless you're mindful, right? Yeah, so the question is, why is it that the withdrawal, what is it about alcohol withdrawal? How is it? Yeah, there's only three drugs that kill you on the withdrawal. Everything else kills you on the intoxication. So cocaine kills you on the intoxication. Heroin kills you on the intoxication. But what kills you on the withdrawal? So alcohol kills you on the withdrawal. What else? PCP, that doesn't really kill you. It could. If it did, it would kill you on the intoxication. I guess if you did enough of it, it could. It absolutely could. If you did it on the intoxication. So, what? But what drugs? What drugs? What? Heroin kills you on the intoxication. It doesn't kill you on the withdrawal. So it's alcohol, benzodiazepines, Xanax, Ativan, Valium, those medications, and then barbiturates, like phenobarbital, for example. So those medications or drugs kill you on the withdrawal. They can kill you on the intoxication. You can die from alcohol intoxication. Ask any fraternity. You can die from alcohol intoxication. But those drugs kill you on the withdrawal. Those are medications that kill you on the withdrawal. And so what happens? Let's see here. The question is still why. We're going to try to answer this question. Why does it happen, right? And so what happens is that it has to do with the receptor systems that alcohol is hitting. So alcohol slows down the brain. But it slows down the brain in two ways. You have excitatory receptors and you have inhibitory receptors. And so would you guess, does alcohol stimulate or inhibit the inhibitory receptor? It stimulates it, right? So you have inhibitory receptors, and alcohol is an agonist to them. So you're going to stimulate the inhibitory receptors, and you're going to block, alcohol blocks the excitatory receptors. So if you're a neuron, and your inhibitory receptors keep being stimulated, the response of the neuron is going to be to make less of them. Right? They keep being stimulated. I guess we don't need them. We don't need as many of them. So let's make less. So you're going to make less inhibitory receptors. And if you're a neuron and your excitatory receptors keep being blocked, then the response of the neuron is going to be to make more of them. Right? It's like, gosh, my receptors keep being blocked. I need more of them. So you're going to make more excitatory receptors. So now you're drinking. You have all of these excitatory receptors. You don't have any inhibitory receptors. And now you run out of alcohol. So now you have all of this excitation. You don't have any inhibition. And what happens? You have a seizure, right? Because you have all this excitation and no inhibition. So now you have a seizure, right? And it's through, so alcohol withdrawal, the way it kills you is through, it's sort of like brain failure, if you will. It's just brain failure. It's like delirium, it's brain failure, and it just shuts down all of your organ systems and your physiology in the same way that people have heart failure or kidney failure or liver failure, this is brain failure when this happens. And it just disrupts your physiology and you die. The other way it can kill you, it's not really on the withdrawal though, not necessarily, is through aspiration. So aspiration pneumonia is the other way. But this is much more common. Okay? So let's see here. Okay, so at low doses of alcohol, you get increased dopamine. Dopamine is what makes you feel good, right? Dopamine, you feel good. Dopamine gives you that high feeling. And so at low doses of alcohol, you get kind of this dopamine influx, and you get that high feeling that people can experience. However, at high doses of alcohol, you increase the inhibitory receptors, which are GABA, and you decrease the excitatory receptors, which are NMDA, and now you just get sedated, right? So eventually you no longer feel high, you just feel sedated, right, at higher concentrations. All right, so again, alcohol withdrawal delirium, it occurs about 72 hours after the last drink. And the symptoms, we talked about all these: tremors, blood pressure, increased pulse, temperature, hallucinations. We talked about all of those. And I'm going to skip that slide, and we're going to talk about how we treat it. So how do you treat, if you're worried about alcohol withdrawal delirium, how do you treat that? How is that treated medically? You know? What medicines do you use to prevent alcohol withdrawal? You use sedatives. You use medicines like Ativan, and probably Ativan and Valium most commonly, right? And so people will say, well, why would you do that? Why would you give a sedative to an addict? Why would you do that? Why would you do that? So what will happen is that, again, if you have all of these excitatory receptors that are being blocked, you have all of these inhibitory ones that are being stimulated. When through the upregulation and downregulation, there's nothing you can do about the excitatory receptors. But what you can do is you can just put the brain on ice. You can inhibit the brain. You can keep the brain on ice. You can inhibit the excitatory tone. And the way you inhibit it is with medicines like Valium and Ativan. So there's nothing you can do about the excitation, but what you can do is you can sedate the brain and then taper these medicines so that the brain slowly over time comes back online. And that's what's done. So the other way to do this, what some hospitals, and this doesn't really happen anymore, but what some hospitals used to do, they just put them on an alcohol drip. Right? It would just be an alcohol drip. And you would just slowly taper the alcohol in the alcohol drip until the brain came back online. So the way that we prevent alcohol withdrawal delirium, DTs, is with medications that sedate the brain, that slow the brain down. Most commonly, that's going to be Ativan or Valium or Librium. Okay? That's how we treat it. And so if a patient is high risk when they're admitted to the hospital, we'll just put them on these medications automatically. Right? We'll just start Ativan 4 times a day on day 1, 3 times a day on day 2, twice a day on day 3, once a day on day 4, and then discontinue. We'll just put them on this Ativan taper to ensure that they don't go into DTs. Okay. So alcohol can also just lead to dementia, different dementia syndromes. Korsakoff's and Wernicke's, a lot of these are due to the associated vitamin deficiencies. So these are when people just kind of drink their supper every night. They deplete themselves of vitamins, thiamine, B12, these kinds of vitamins. And it's through the vitamin deficiencies that they start to develop cognitive problems and then functional loss related to the cognitive problems. So the first kind of that's why, like, when someone is being detoxed, you know, they have the banana bag, right? Have you seen the banana bags in hospital ERs? Like these IV, they're getting an IV. It's called a banana bag because the fluid in it is yellow. Right? It's like this yellow fluid dripping into them. The yellow fluid has all these vitamins, and so what the ER docs are doing is putting vitamins, depleted vitamins, back into the patient to prevent different neuropsychological sequelae. And so that would be with Korsakoff's and Wernicke's. Wernicke's is more kind of the signs of Wernicke's that you'll see. Wernicke's will affect the way that people walk. So they'll have this kind of wide-based stance. They'll have what's called ophthalmoplegia. They won't be able to move their eyes. So like right now, I can sit here, I can follow my finger without moving my head. When people get Wernicke's, when they get these alcohol-related vitamin deficiencies, they can note their eyes are just locked in place, and they can only look straight. So I'll have patients, I'll be on call at University Hospital, and I'll tell a patient, okay, I want you to follow my finger. And I'll start moving my finger, and they'll just look straight at me. I'll say, no, 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 just follow my finger. And they'll look straight at me. I'll say, no, 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 just follow my finger. And they'll say, I am. Right? But they're not. So we have to be mindful of that. And then what also happens, the other way that alcohol induces dementia, it has to do with the starting and stopping, the starting and stopping, the starting and stopping of drinking. So by starting drinking, and then you stop, and then you start, and then you stop, and you start, and then you stop, you introduce the opportunity for free radical damage and cell-mediated, apoptotic-mediated cell death. And so the starting and stopping, the starting and stopping, the starting and stopping increases free radical damage in your brain, which kills the neurons. So sometimes you'll hear people say, you know, he would be better if he would just keep drinking, right? If he would just keep drinking, I think he'd be better. But on one hand, that's true. On the other hand, he'd just have other problems. So dementia, the way the dementia works is by, it's kind of the start and stop, start and stop, start and stop of the drinking behaviors. And so if you look at thiamine deficiency, this is when people start to, again, they just stop their nutrition. They are only drinking, alcohol is their only nutrition. You have these little structures here called mammillary bodies. They're in green right there. These little hypothalamus structures right there. So over here, these little green things are called mammillary bodies. And they're very sensitive to thiamine deficiency. And once those things, if you have too much thiamine deficiency, then you'll get their eyes no longer move. They have the ophthalmoplegia. They become much more confused. They have retrograde amnesia. They can't remember things that have happened in the past. Confabulation, they'll just make things up. So if you say, what did you have for breakfast this morning? They'll say, oh, I had eggs and I think some toast with some grape jelly and a side of bacon. And then you'll ask the nurse, well, what did they have for breakfast this morning? Oh, it was oatmeal. Right? They just kind of like, they're not trying to lie to you, it's just they sort of unintentionally make up answers, if you will, like children. Okay, so, and then finally, with the thiamine deficiency gets too bad, and these mammillary bodies go offline, it can result in coma and then death. Right? Coma and then death. And that's from the vitamin deficiencies. If you look at brain volume, kind of the starting, stopping, starting, stopping, starting, stopping, every time you start and stop, heavy drinking, you're killing neurons. Every time that happens, you're killing neurons. So this right here is brain volume. On the y-axis, you have brain volume. And then on the x-axis, on the far left, you have abstainers, people who don't drink. You have former drinkers. You have people who drink low amounts, moderate amounts, and high amounts. Right? So abstainers, former drinkers, drinking low amounts, moderate amounts, and high amounts. And what you can just see is that as you drink alcohol, the more you drink, your brain just gets smaller and smaller and smaller and smaller. Right? Alcohol makes your brain small, is what it does. So this is like a 43-year-old, right? 43-year-old alcoholic. So here's like a normal 43-year-old brain. You can see how the brain is reaching the skull. Right? And then you just look at the 43-year-old alcoholic, and you can just see that his brain is much smaller than the normal brain. Right? And that brain right there, much smaller than the normal healthy brain. It just eats up and eats up and eats up. The free radical damage just eats up and eats up and eats up at the brain. And it just makes your brain small. And then before you know it, you're, 45, 50 years old, and you have an alcohol-related dementia. Right? You just cannot think. You have all these cognitive problems and using. Okay. Good. All right. That's all we got. Any questions about alcohol? Yeah. So the question was, when it comes to starting and stopping, what is the frequency? Now, these are the people who've had, 5 or 6 periods of sobriety in a year. Right? So I was sober for 2 weeks here, and I was sober for another 2 weeks there, and then another 2 or 3 weeks here. It's that type of frequency. It's not over the long term. It's kind of the starting and stopping over short terms. Yeah. Some will say that. You'll hear people say that they would just be better if they drink smaller amounts all the time than heavy amounts starting and stopping because of the oxidative cell death. Yes?
When someone is diagnosed, say with alcoholism, I know there's a drug, I don't know the proper, name for it,
Yeah.
but I know it causes vomiting. It has
Yeah.
vomit with the introduction of the alcohol.
Yeah.
Is that routinely prescribed?
So that's disulfiram or anabuse, right? So anabuse is the brand name for disulfiram. It's a acid aldehyde dehydrogenase inhibitor, and so what that, to make a long story short, it causes this right here, acid aldehyde, to build up, and that acid aldehyde causes you to feel incredibly sick, right? And you get the flushing reaction and the vomiting, and you just feel awful, right? And so, so that's how that medication works. And so your question is, the question is it routinely prescribed? Yeah, it is. It is routinely prescribed. Maybe not prescribed as often as it should be, but it is routinely prescribed. The other medication that's used probably more often than disulfiram is naltrexone. So naltrexone is a opiate agonist-antagonist. So it essentially takes away the sort of the cravings or the pleasure that one would experience from alcohol. And so naltrexone doesn't have it doesn't cause the physical sickness that disulfiram or anabuse causes. It just kind of it makes alcohol not pleasurable. You don't get that positive reward from it. And so that medication is prescribed probably more often than anabuse is.
Hi, I have a question. Are there any dietary interventions or nutrition guidelines recommended to be protective factors through research that have been studied? Like lower animal or protein intake or saturated fats or...
With regard to alcohol?
Well, no, I'm sorry, it's not alcohol related, but Alzheimer's or dementia.
Oh, with regard to dementia? So,
yes.
So yes is the answer, right? So the answer is there have been studies about what have there been? It's the stuff that we all kind of know. It's the leafy green vegetables seem to protect the brain better. Lower amounts of red meat seem to protect the brain better. It's kind of the usual stuff. I think that's kind of the frustrating part, if you will, of dementia treatment is that diet seems to help. Exercise seems to really help as far as prevention. But getting people to do that is like really hard, right? I mean, it's just so hard. And so I think that's, my heart goes out to the, to people with, holistic mindsets. I wish there were more. Yes.
Does this information also pertain to bingers and maybe those that drink maybe 2 of the 6-ounce beers, or what is it, 12 ounce?
Yeah.
Beers, a day, or how does
Yeah.
how does that pertain to them?
So how does it pertain to binging, right? So the answer is yes. I mean, it does pertain to the bingers, right? And so the problem with binging is that you're overloading a naive system, right? So you're overloading a naive system with alcohol. So probably the biggest problem, like a good example of that would be, I kind of said with fraternities, but the truth is like in college, where they might not drink Monday through Wednesday, but then Thursday night is college night, right? And then you'll see, sort of the alcohol intoxication deaths, if you will. right? And so it's just overloading an alcohol-naive system with alcohol. And that increases definitely mortality, but also morbidity as well. That's kind of how, there's kind of two, there's sort of two, alcoholism is classically divided up into type 1 and type 2 alcohol. And so, let me get this straight. Type 1 alcoholics are people who, they started maybe experimenting with alcohol in high school or college, and then they got a job, and then, they ended up in their late 20s or early 30s, they start drinking a little bit more, and then by the time they're in their early 30s or mid 30s, now they're drinking every day, and by the time they're 30 or 40 or so, they're just drinking continuously, and now they're alcoholics. The type 2 alcoholics are the ones who, their mom is an alcoholic, their dad is an alcoholic, they started using alcohol at a young age, and they never graduated from high school or went to college because of alcohol, and those are type 2 alcoholics. And so type 2 alcoholics, type 2 alcoholism seems to be more mediated by genetics, whereas type 1, kind of you sort of catch it as you go on through life, seems to be mediated more through social situations. And so, so we'll see that kind of with the binging. The binging tends to affect more the type 1s, whereas the type 2s are more vulnerable to just the continuous everyday drinking, mediated through perhaps genetics. Right, so the question is what is binge drinking considered? Is it considered alcohol abuse or dependence, or what is it? So with binge drinking, you just have to ask yourself these questions. So if a person is binge drinking, are they taking alcohol in larger amounts than they intended? So did they sit down that night and intend to drink a liter? Right? Maybe they did. I don't know. Does the binge drinker try to limit or discontinue consumption? Do they spend a lot of time doing that? Are they craving when they binge? Is it mediated through cravings? And so this applies to binge drinking and continuous drinking, right? And so if they're binge drinking and they're driving, so if they're binge drinking and they're getting in the car and they're driving, they're failing in school, their mom is mad at them because of the binge drinking behaviors. It's affecting interpersonal relationships. They're drinking more than they intended to drink. Well then, yeah, they have an alcohol use disorder, even through binge drinking, right? Yeah. 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 Yeah, so the question is, can alcohol-related dementias be reversed? I have to believe that they can. I just haven't seen it. Right? I just haven't seen it. Because you can imagine that if your brain has shrunk and shrunk and shrunk and shrunk, then that brain tissue is not going to grow back, right? So I do think that so clearly when people are intoxicated, they're incapacitated, and once they sober up, they can recapture their capacity. But all of the cases that I've seen, they don't recover. I think the other problem with kind of alcohol as it pertains to dementia is all the traumatic brain injuries that they suffer. They're falling all over the place and hitting their head, and so they have these other problems as well. So it's a good question. It's a really good question. I'd like to believe they can. I just don't ever recall seeing that. Yeah. Any other questions? All right. Well, again, I'd like to thank Doctors Hospital for letting us use this incredibly beautiful space. Thank Adult Protective Services for helping host the event. Thanks to the Alzheimer's Association and all the information that they gave us. Thank all of you all for your incredibly kind attention. Thank you all so much.
Thank you, Dr. Schillerstrom. We got some words from the APS, Do I go up here or top right?
right
Okay,
here.
right here.
Well, on behalf of Adult Protective Services, I do want to thank you, Dr. Schillerstrom, for your presentation. And I do have a realtor on standby because I have been told repeatedly throughout the conference if we can move you down to the Rio Grande Valley so that you can provide your expertise to us. And so she will be meeting with you this afternoon. But this has been, I think, in my experience here with Adult Protective Services, one of the premier presentations that we have had here, and it is all related to you and your delivery. And so, thank you so much for this conference. For someone to carry a conference for a full day, one person is quite a feat. And so, thank you so much. I was telling some of you earlier, you know, we keep you all here, and to keep you here all day, we feed you throughout the day. So, Doctor's Hospital, and please, if you see, well, Esther Fuentes is in the back. Thank you so much for your hospitality and generosity, and it's very, very much appreciated. Thank you, Esther. And once again, thank you all for joining us. I only have one recommendation, that if you're doing this on a Friday afternoon, that you do the alcohol piece at the beginning, so that I don't feel guilty running to happy hour after your presentation. I may have to rethink that. It's a gym or happy hour, I don't know. But with that, I will go ahead. I know that there's a bit of housekeeping and some CEU pieces that you need to be given some information on. But once again, on behalf of APS and the rest of our sponsors, thank you so much. It was a pleasure meeting most of you, some old friends that I hadn't seen in a very long time, some old teachers that I hadn't seen in a very long time. Thank you all for being here. Esther.
Thank you, Annie. Okay, get your blue tickets out. We're gonna finish doing some door prices. We're gonna raffle off some 27 door centerpieces. And then those of you that don't win something, we've got a little extra something for you with Gus at the back. And again, on behalf of Doctors Hospital at Renaissance, Behavioral Hospital at Renaissance, thank you so much for being here and for taking part in this today. Very important.
That's right, because if you don't show up, we don't have a conference. So it's really because of you that we're here. We need you to be here. We need you to be hungry for this type of education. And this is even a surprise to me. I don't know what you have up your sleeve. What kind of, okay, yeah, poker face. Remember that?
Happy hour.
Happy hour. Okay.
Yeah.
So you want to start calling numbers?
Let's start calling some numbers.
Okay.
Just a real quick reminder, we are going to have an open house here on May the 13th. It's on a Wednesday. It's a little social. Kind of do a program overview of our behavioral hospital at 6 o'clock. I'll be sending some invites, so make sure that you signed up and left your email address for May the 13th on a Wednesday. We're celebrating Mental Health Awareness Month next month. Okay, let's get started.
Okay, our first number is 253. There we go. Winner right there. This is a, wow, look at this. It's a Coolpix S32 Nikon water camera. So we're gonna go scuba diving. Can I have your name and institution, please?
It's Lisa Peña, and I work for Regency in the Valley.
Regency, yeah. This is a $25 gift card to Banana Republic. Wow, nice, very fancy. Okay. 306. 306, hands nice and high. Get your hand up. There we go, right there. Winner.
Okay, we had 31 centerpieces and we gave 5 away, so that means we have 26 left.
That's right.
Okay.
Good math. Okay.
All right, so those of you that won your centerpiece earlier, put it underneath your chair or something.
Yeah, take
so
them
we'll
off.
know how
Take them
many
off
are
the
left.
table.
Take them off the
Go
table.
to
Now
if
we're
you
gonna
won,
raffle
go
them
take them
off.
off your table. There you go. And your name and institution?
Lucy from Edinburg CISD.
Oh, not even last name. If you know Lucy, you know Lucy. Hey, I don't need last name. Okay.
Okay,
This is for a centerpiece, correct?
centerpiece, yes.
Okay. 257. 257. Oh, there we go. Woo, she's excited. All right.
That's 2, right?
That's 2. 311. 311. There we go. Winner right there.
Get up and grab one.
Grab your closest bouquet and just,
Claim it.
yeah. Elbow someone in the face if you have to. Just grab it. Throat punches. Okay. 370. 370. 370. 37. Winner right there. Okay. Grab that plant. 327. 327. 327. 327. Winner right there. All right.
Okay.
Grab it.
Grab it from the table.
Please don't forget it.
How many more do we have?
I don't know. 271. 271 right there. Where is the one on your table? It's already gone? Okay.
Turn around and grab one.
Yeah, find the closest one. Wrestle it, arm, you know. Chokehold. 240. 240. Where are we at? Oh, there we are. Okay, right there. Okay. Awesome. I lost count totally.
Is somebody keeping count?
Someone?
18. Okay, great. Thank you. Woo! Thank you.
What's your ticket number? 358. 358. 358. The winner right there. Okay, okay. She was.
He's
Is that too sure?
Respect. Nobody pushed him around.
That's right. Don't push me around.
Nobody made you behind his back. Nobody told you.
355. 355. Where? Bingo. Wait, where? Okay, awesome. Okay, get the nearest plant. Grab it.
Hurry before we raffle it off.
Yeah. 310. 310. 310. No? Seriously? You? Okay. 310, they're right there, okay. Woo, all right, grab the nearest one, wherever it is. I know someone stole it from you. Yep, yep. Okay. 380. Boom, bingo, right there, sir. You got it. Is there one on your table? Now there is. All right. 379. 379. Right here. All right. Has that one been claimed? Has anybody gotten that one? Okay, so get your closest one. Sorry, ladies.
Is that out of play?
How many got left, sir?
Okay, take it up, put it on the chest. Let's see how many are out of
Nobody's
play.
keeping count.
No. Seriously? 14? 14?
14.
Oh, okay. 279. 279. 279. Anybody?
Does somebody have a birthday today?
There we go. 279. Right there.
Anybody's birthday? Anniversary?
No.
No?
No.
Okay. I tried.
424. 424. That's you. All right.
All right,
Congratulations. 357. Magnum. There you go. All right. There he is. Where's the nearest one? Grab it. Go in there like a thief and take it. Oh, you scared that lady. 414. 414. There you go. 414. Okay. All right. Congratulations.
How many do we have?
And she was one of our volunteers. Awesome. Where's the nearest one? It's not yours. It's hers now.
There's some over here on this side of the room.
Where's a free one? Okay, there it is, right there. Go and grab it. How many left?
Raise your hand on the table if you still have a centerpiece available.
and it's not yours.
And it's not yours.
We got 1, 2, 2 more. Okay, 350. 350. 350. Where? I want some hands. Hands. Raise it up high. There you go. All right. Awesome. Okay, it's going to be located on this side of the room. Last one. 376. 376. There we go. Last one right there. Awesome. Very good. And this lady right here got her flowers and she's out of here.
Those of you that didn't win a centerpiece or a door prize today, you didn't win, sir. I'm so sorry. Give this man one of those tumblers. If you didn't win anything, go by, raise your hand, Gus. And there's a little tumbler there that you can use to drink water or put in your, not alcohol.
Whoa. Before you go, we still got a lot of paper. Well, hold on, take your seat. Take your seat. I got some paperwork we gotta get. Okay, would my volunteers, Juana, Iris, and Clarissa, please come up to the front, please? They've been your volunteers for today. If you're volunteered today for us, would you please stand up? Give you a round of applause. Just thank you so much for your time and effort. Thank you very much. Would my 3 volunteers who will volunteer for the final project please come down? Okay, they're going to be collecting paperwork from you today. When you turn in your paperwork, do not turn in your pal's paperwork or your friend's paperwork. You must turn in your own paperwork. Okay? No cheating. Okay, so Iris here is going to collect the DVD forms, right? No, sorry. The statement of attendance forms. They're going to be the sheet that you have to tear apart. We only want the first page, and the back of the page is the continuing education credits. We're going to give that to her. Juana here is going to collect the statement of attendance. I'm sorry, the participant profile form. That's the demographic stuff, information, so we can help grant funding for future conferences. And the last page will be the DVD form for Clarissa here. And the Brownsville Educational Summit we're going to have on May 30th. If you fill that registration form out, he's going to collect that also. Okay? So again, just thank you so much. You're welcome. For this opportunity. Thank you so much for coming down. Be sure to grab a tumbler. And what else do you have for us?
I think that's about it.
Okay, just be safe, drive home, and take care.
God bless
And
one of you.
thank you very much for coming. And don't forget to file. I'm going to email everyone a evaluation electronically, and wait a couple of days so I can email you your certificate. So thank you so much for coming, and take care. God bless.
Have a great weekend.
Won't you see about me? I'll be alone, dancing, you know it, baby. But tell me the troubles and doubts, giving me everything inside me now. The love string, so real in the dark. Think of the tender things that we were working on. The slow change to pull us apart. When the light gets into your heart, baby, don't you forget about me. Don't you forget about me. Will you stand above me? Look my way, but never love me. Rain keeps falling, rain keeps falling. Will you recognize me? Will call my name or walk on by me. Rain keeps falling, rain keeps falling. Won't you try and pretend it's my feeling? You'll get in the novel. Call me, or touch your defenses. Lord, Don't you forget about me. I'll be alone, dancing, you know it, baby. Going to take you apart. I'll put us back together in heart, baby. Don't you forget about me. Don't you forget about me. As you walk on by, will you call my name? As you walk on by, will you call my name? And you walk away. Will you walk away? Will you walk on by? Come on, call my name. Will you call my name? Say la, la 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 la, la 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 la, la 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 la.